All right, good morning. I think we'll get started. It's my pleasure to introduce today's Grand Round speaker, Dr. Jaya Ganesh. Dr. Ganesh is a professor in the Department of Genetics and Genomic Sciences and the Department of Medicine at Mount Sinai. She's an attending physician in the Division of Medical Genetics and Genomics. Her clinical interests include mitochondrial diseases, lysosomal storage diseases, and other inborn errors of metabolism. She is the director of the Mitochondrial Disease Program. Dr. Ganesh completed her medical training in India, followed by a fellowship in medical genetics and clinical biomedical genetics at the University of Pennsylvania in 2004. She joined the faculty of the Department of Genetics at the Icahn School of Medicine in 2018. She is the principal investigator for several therapeutic clinical trials, including AAV-based gene therapy for Fabry disease and enzyme replacement therapies for acid sphingomyelinase deficiency, homocystinuria, and arginase deficiency. Dr. Ganesh established the Medical Biochemical Genetics Fellowship at Mount Sinai and serves as the program director. She is passionate about medical education and was awarded the 2023 Excellence in Teaching Award from the Institute for Medical Education at Mount Sinai. Please join me in welcoming Dr. Ganesh.
Thank you so much for that gracious introduction, and thank you to Dr. Malone and the Chief Resident team for inviting me, and good morning to all of you. Um, Mitochondrial diseases have been a passion of mine since I joined in fellowship, and I had the privilege of discussing my very first case with Dr. Salvatore De Mauro at Columbia. And he is one of the greatest mentors one could ever have. And over the course of 30 years, my collaborations with Columbia have grown. And almost on a case-by-case basis, we discussed this. And when I started my fellowship, diagnosis was hit or miss. We had muscle biopsy, we had some biochemical testing. But in 2010, 2015, when the whole genome sequence became known and we had molecular testing, the diagnosis of these disorders exploded. And consequently, therapies have exploded. And we are now doing solid organ transplants and running into gene therapy and other novel treatments for these diseases. And I'll share some of that with you. Most of the information I'm presenting here is in the public domain, but I will be talking about some therapies that are still in trials, which are very promising and hopefully will get approved soon. And though I do serve on various advisory committees and receive research funding from pharma, none of those relationships are relevant to my talk today. So the goals are pretty bold today. We'll talk about mitochondrial function, the mechanisms of disease, and importantly, the inheritance patterns, and how do you recognize and diagnose these patients, and what are the kind of investigations that we do and treating. So as a group, these are disorders primarily involved in energy production. And so when there are climactic mitochondrial diseases, there is impairment in oxidative phosphorylation. And they are a very heterogeneous group of disorders, and they present across various subspecialties and across various age groups. And actually, they are the most common neurometabolic disease across the age spectrum, mostly in pediatrics, but even in adults, if you think about it, they are pretty common, and we are probably missing many of the most subtle ones. And the incidence is about 1 in 5,000 live births. If we ask a geneticist, what's the incidence of Down syndrome, we would say 1 in 800 live births. So that's the rarity and probably the common nature of these diseases. And they may be due to defects of either the mitochondrial DNA or the nuclear DNA. So there is a dual genome inheritance, which we'll talk about. And the diagnosis is primarily made, and the first step is a suspicion for these diseases. And as you know, these are subcellular organelles. There is a outer mitochondrial membrane, which is very, very permeable. But the inner mitochondrial membrane that is thrown into these folds called cristae is quite impermeable and needs special transport facilitation to carry cargo in and across the membrane. And the matrix is the seat for many metabolic pathways. And within the mitochondria are separate genetic material called the mitochondrial DNA. And as a rule, mitochondrial DNA is inherited exclusively from the mother. It's a maternal inheritance. There are rare exceptions where some paternal inheritance mitochondria can come through, but for the most part, it is maternally inherited. And the primary role, as I mentioned, is oxidative metabolism. They are the batteries or the powerhouses of the cell. But in that function, there is also production and management of reactive oxygen species. And some of the toxicity in mitochondrial diseases is due to a mismanagement of reactive oxygen species. They are important in calcium homeostasis. They regulate cell death and apoptosis. If your mitochondria are aged and die, your cell dies. They are important in gene regulation and hence control nuclear function by retrograde signaling. And several metabolic pathways reside within the matrix, starting from oxidation of pyruvate following glycolysis, beta oxidation of fatty acids, Krebs cycle, urea cycle, phospholipid synthesis, you name it. Many of these enzymes are represented in the mitochondrial matrix. And measurement of these intermediates can help us determine, to some extent, the dysfunction of mitochondrial biology. So this is a slide that kind of oriented me to energy metabolism, so I'll share it with you. So in the universe, the source of all energy is basically the sunlight, photons, and the plants are able to trap this photic energy through the chloroplasts as chlorophyll. And we, as higher organisms, feed on the plants or feed on the animals that feed on the plants. So our diet looks like this. But in the plants, the carbon dioxide, atmospheric carbon dioxide, and water, plus photic energy is converted to starch, glucose, and this is a molecule of glucose. And that photic energy that's coming is really trapped as these hydrogen bonds in these glucose molecules or proteins or fats. So when we consume that nutrition, our metabolism deals with them as carbohydrates, as triglycerides, or as proteins. We break them down into much smaller carbons in the process of normal metabolism. But if you recall your biochemistry, each time these reactions occur, there are many instances where the NAD cofactor is reduced to NADH, and further metabolism of these compounds happens. So by the end of this breakdown, we've broken down our nutrition into small carbon chains that are fed into the Krebs cycle, and you burn it off as acetyl-CoA. But these reducing equivalents, this hydrogen that is trapped, is taken to the mitochondria. And in the mitochondria, the NADH is oxidized to NAD, and the FADH2 is oxidized to FAD. So you regain your equivalents. But what happens is all that hydrogen is combined, the protons are pumped, and the electrons of hydrogen are transferred to oxygen. And so oxygen is reduced to water. And the pumped protons generate energy, and that energy is trapped with ADP and inorganic phosphate to form ATP. So this is oxidation and phosphorylation. And essentially, through all of this, what you have done is you have taken this photic energy that was trapped as hydrogen bonds, and you have converted it into a chemical energy that you can use as ATP. And that's what the mitochondria do for you. And how do they do it? These are the mitochondrial complexes. This is the outer mitochondrial membrane. This is the intermembrane space, the inner membrane, and the suspended in the inner membrane in the matrix are these complexes. There are 5 of them, complex 1, 2, 3, 4, and 5. And the flow of electrons is always from complex 1 towards complex 5. And complex 1, the largest of the subunits of this energy circuit diagram, will oxidize NADH to NAD. And the protons from the hydrogen are pumped into the intermembrane space. The electrons are transferred to coenzyme Q, or quinol, coenzyme Q, and coenzyme Q carries these electrons all the way to complex 3. In complex 2, FADH2 is oxidized to FAD. No protons are pumped, but the electrons are transferred. Again, Q is the electron carrier. And eventually, the electrons that reach complex 3, more protons are pumped out, but these electrons are then transferred to another electron carrier called cytochrome C. Cytochrome C carries the electrons to complex 4, and at the level of complex 4, these electrons are donated to oxygen to reduce it to water. But what's happening in the intermembrane space? There is a whole positive charge. Lots of protons have been pumped from the previous complexes, and so that is not compatible. So the electromotive force is set up, and all the protons come as a unified force via complex 5 or ATP synthase. And this is a rotor. And as the protons are pumping, that force rotates the rotor, and that torque is used to combine inorganic phosphate with ADP to form ATP. And ATP is here in the mitochondrial matrix. It needs to be transported out of the mitochondria. And so there are transporters that transport the ATP out. So this is oxidative phosphorylation. And these are the various subunits that are involved. Now, where do we get these subunits from? How are they made? And that is mitochondrial genetics. So this is mitochondrial DNA. This is, as I said, maternally inherited, a small circular piece of DNA, just about 16,569 base pairs. And what it encodes is it encodes some subunits of these complexes that I've talked to you about. So it encodes 7 of the complex 1 subunits. None of the complex 2 subunits are encoded on the mitochondrial DNA, but 1 of complex 3, 3 of complex 4, and 2 of complex 5. So it's not necessary to remember these subunits, but just suffice it to say that some of the complexes have a dual inheritance. So 7 of the 42 are encoded by the mitochondrial DNA. The remaining 42 minus 7 are coming from the chromosomal DNA or the nuclear DNA. Whereas complex 2 is exclusively inherited from the nuclear genome. You don't inherit it from any of the mitochondrial subunits. That's an important distinction to remember. In addition to these complexes, the mitochondrial DNA encodes its own transfer RNAs. So 22 transfer RNAs are coded by the mitochondrial DNA, and its replication machinery, ribosomal RNA, the 12S and 16S Fedberg units are present. So there are 2 to 10 genomes per mitochondrion, and there are anywhere from a few mitochondria to 10 to the power of 2 or 10 to the power of 3 mitochondria per cell. So a very metabolically active cell like the muscle or a liver cell or an oocyte will have a very high number of mitochondria per cell, whereas a skin fibroblast, which is not metabolically that active, may have fewer mitochondria. So that is why skin biopsies are not the best tissues for mitochondrial DNA and biology assessments. Maternally inherited, no introns, and importantly, it lacks repair machinery. And mutations in the mitochondrial DNA are common, and there's a very high mutation rate, and there is always a population in patients of normal mitochondria and diseased mitochondria, the mitochondria that have accumulated so many of these mutations, and that is called heteroplasmy. So a patient may be a mosaic of normal and diseased. And a patient who has a very high level of heteroplasmy or even homoplasmy for mutant mitochondria exceeds the threshold for disease in that particular tissue and develops symptoms. So here are the 37 genes, the 13 proteins, 22 tRNAs, and 2 rRNAs of the mitochondrial genome. But the OXPHOS machinery is a lot more complex. It's many, many more subunits. And then you have to have other things that transport cargo in, all the enzymes, etc. Where does that come from? They all come from the chromosomal DNA. So about 1,500 proteins are involved in this oxidative phosphorylation. And so these come from so both the genomes interact to create that OXPHOS machinery. And as you are sitting here, many of us, most of our tissues are post-mitotic. Our liver is not constantly growing. Our muscles are not constantly growing unless you're exercising and building muscle. However, and our nucleus, our cells are not constantly dividing. Whereas in these metabolically active tissues, the mitochondria continue to divide. And so the genetic machinery for mitochondrial replication also comes from the nuclear DNA. And mitochondrial disease can be either due to defects in the mitochondrial DNA or in the various chromosomally inherited genes that come from the nucleus. So here is how it looks like. So this is complex 1, complex 2, 3, 4, and 5, and highlighted in red. It's almost like you take a Lego structure and you assemble it together with these various subunits. And so that's how these things are assembled. All the blue are the nuclear encoded subunits, and all the red are mitochondrially encoded subunits. Complex 2 is exclusively nuclear encoded. And so there's the unique aspects of mitochondrial DNA. We talked about heteroplasmy. So here is homoplasmic wild type or normal DNA. Sometimes a mutation may occur. So here are two mutant mitochondria which carry mutant mitochondrial DNA. And as the cell divides, there can be segregation of these mutant mitochondria in such a way that some cells may get more of the normal components, some cells may get more of the mutant component. And so that is mosaicism is called heteroplasmy. And a patient may actually be almost homoplasmic for mutated mitochondrial DNA. And depending on the tissue, the level of mutation, the threshold for the disease varies. And if this is an oocyte, there is a bottleneck, a genetic bottleneck. Very few of the mitochondria enter that mature oocyte. But once they enter, again, they can divide. And so the offspring that inherit these mitochondrial DNA, the degree can be variable. You can have a woman with some mitochondrial DNA mutations transmitting very few to one child, a different proportion to a different child, and almost homoplasmy to a third child. So within the family, there can be multiple children with various manifestations of mitochondrial disease. And this oocyte, when it's fertilized, may again go on to divide into various organ systems. And so a child may have, with MELAS, for example, which is a mitochondrial DNA defect, may have just Leigh syndrome and extensive brain damage. His sibling may be completely normal, but may develop mitochondrial deafness and diabetes at the age of 40. And a third sibling may be completely normal, but may go on to have children with mitochondrial diseases. So any inheritance, any organ system, any manifestation is common in these disorders. And mitochondrial DNA has a maternal inheritance. And for those of you taking boards, if you're given a pedigree like this, make sure you look at the things. Males are in squares, females are in circles, and no male to male transmission. And there is no male to female transmission, unlike X-linked disorders. And it is always transmitted from the female to the next generation. And females can transmit the disease to males and to females. So the manifestations, any symptom in any organ, any tissue, any age, any mode of inheritance. So to the right are the neurological manifestations. Why brain? Because the brain, it's a very high energy demand. And so when there is a problem with the batteries of the cell, the brain and the high energy beds tend to suffer. So if you have that concept in mind, you can almost predict what are the kind of symptoms that these patients will have. So seizures, strokes, epilepsy, ataxia, migraine, and then developmental delay in children, movement disorders, and then the eyes, there is ptosis, ophthalmoplegia because of the weakness of the muscles. There can be optic atrophy, retinitis pigmentosa, sensory neural hearing loss, myopathy, exercise intolerance, fatigue is a big thing in mitochondrial diseases, and peripheral neuropathy. So these are the neurological symptoms. And the non-neurological symptoms, basically respiratory failure because of mostly diaphragmatic or intercostal involvement. Cardiomyopathy could be dilated, hypertrophic, or a non-obstructive concentric hypertrophy. Conduction defects, heart blocks, WPW syndrome, all common. Liver failure, more in the pediatric population. The kidneys, focal glomerulosclerosis, minimal change disease, chronic kidney disease, anything is possible. And then some of the more recent advances are the diabetes, the endocrine failure. They can have hypoparathyroidism, adrenal insufficiency. And more increasingly, you are seeing these patients present in fertility clinics with premature ovarian failure, male infertility. They can have GI dysmotility because of peristalsis is affected, vomiting, cyclic vomiting, pancreatic insufficiency, and bone marrow failure. So these are the non-neurological. But so most of these high energy beds are affected because of this energy defect. And here are some phenotypes per age group. If you see in children, the nervous system, metabolic defects, and the myopathy and growth failure are pretty common. Whereas if you look at adults, you again have the neurological, not so much metabolic imbalance. Why? Probably because some of the nuclear defects that you see in adults are relatively milder, and so they don't manifest that much. And when I say metabolic defects, I mean lactic acidosis or a disturbance in glucose metabolism or fatty acid metabolism. We'll talk about that. Myopathy is a predominant symptom. Vision is a predominant symptom. Leber's hereditary optic neuropathy, progressive external ophthalmoplegia, etc. Hearing loss is pretty common, and the endocrine system is more affected in the adults than in the pediatric population. So here is the mitochondrial wheel, and superimposed are these various disorders that you typically associate with mitochondrial diseases like MELAS, cardiomyopathy, LHON, etc. And these can either be due to mutations, which are point mutations, in the mitochondrially encoded respiratory subunits, which are in the salmon pink color, or in the transfer RNA, which are in this light blue color, or even in the ribosomal RNA, as in the case of aminoglycoside-induced deafness. So any mutation anywhere along the wheel can give you a phenotype. And as you can see, MELAS can be a mutation here or a mutation here. So MELAS just refers to the phenotype of mitochondrially inherited lactic acidosis stroke-like episodes. But that phenotype can be due to many, many reasons of point mutations in the mitochondrial DNA. And here is a superimposition. Up top in red are the mitochondrially inherited defects, and down below are the nuclear inherited defects. And as a rule, nuclear inherited defects tend to be more severe, and the most severe phenotype is seen in the pediatric population. But with exome sequencing and genome sequencing approaches, we are picking up increasingly many more nuclear defects in the adult population. Mitochondrial diseases, DNA defects, tend to be more common in the adult population, but we also see them in the pediatric population. So the rule is not very firm. So here are some of the disorders related specifically to mitochondrial DNA. One is mutations in the structural subunits that I mentioned of these various complexes. Some of them are NORP, Leber's hereditary optic neuropathy, or Leigh syndrome. There can be point mutations in protein synthesis, and we'll look at some cases. And then this mitochondrial DNA rearrangement. And here what happens is, this is the mitochondrial DNA. A whole segment of the mitochondrial arc falls off. So this is a single large deletion of the mitochondrial DNA. The size of this deletion can be a little bit variable, but it typically affects this region of the mitochondrial DNA, this arc from ND5 and then all the way down to ATP6. And so this is a single large mitochondrial DNA, and these are called mitochondrial DNA rearrangements. Remember the word single because there are other diseases that I'll talk to you about. So that's the background. Here are some cases. So here is a previously healthy toddler who develops a transient inability to walk following his immunizations. And so any stress, this could be a fever, this could be immunizations, et cetera. This kid was doing okay, suddenly developed and at 24 months, he had another upper respiratory infection. Now he completely is not walking at all. And he's drooling, he's got abnormal eye movements, he's got neutropenia. The neurologist does an MRI. And here in the deep gray, you see these symmetrical lesions. And when you see these symmetrical lesions in the deep gray in the basal ganglia, mitochondrial disease rises to the top of the differential diagnosis. So they call a genetics consult, and we sequence the mitochondrial DNA, and we find that he has a point mutation in one of the complex 5 subunits that is coded on the mitochondrial DNA, ATP6. This is the change from T at position 8993. He turned to a G, and he has a 94% heteroplasmy, very high threshold, even in the peripheral blood. Probably it's higher in the brain. He has a diagnosis of Leigh syndrome. So now we look at the pedigree. And so in Leigh, in this particular mutation, it's called NARP. If you have a very high homoplasmy, heteroplasmy, you develop Leigh's. But if you have a lesser level of the heteroplasmy threshold, you can actually develop minor manifestations. And one of them is NARP. And even more, even less of a heteroplasmy, you can get retinitis pigmentosa. So we looked at his family. This is dad. He's not contributing the mitochondrial DNA. Here is mom. And here is this boy at 2.5 years with Leigh syndrome. And he has a 12-month-old brother. And we looked at his mitochondrial DNA. We looked at the blood. We looked at the buccal. We looked at the heart. And look at his level of heteroplasmy. Pretty high. And this is his 15-year-old sister, so asymptomatic. And look at her level of heteroplasmy. So the counseling for this family will be these two, the sister and this 12-month-old, are at risk for developing, may not be Leigh syndrome, but for NARP. And so we will send them to ophthalmology, send them to neurology for symptomatic management. The mother herself is a carrier, and her level of heteroplasmy is pretty low. And we see this in these pedigrees. And this is NOR, or neuropathy, ataxia, retinitis pigmentosa, with a slightly less but a higher level of heteroplasm. Here is another case, a 19-year-old boy, man, sudden painless unilateral vision loss. All these words are important in Leber's hereditary optic neuropathy. And 3 months later, it started in one eye, and 3 months later, he noticed symptoms in the other eye. And he was tested, and here he has a point mutation in yet another subunit, this time one of the complex 1 subunits, ND4. And it's a pathogenic mutation. And when we looked at his pedigree, this is him, 93% heteroplasmy. His brother, 92% heteroplasmy. With this level, they will probably develop vision loss as well. But his mother also had some symptoms, not necessarily vision loss, but she had a conduction defect and fatigue. So we are increasingly seeing that even though Leber's is hereditary and ophthalmological pathology, we are seeing other organ systems, particularly the muscle and the heart, involved in these patients. And her sister, the mother's sister, has a 23% heteroplasmy, and her children have inherited some, but we don't know when they will be. And so this is Leber's hereditary optic neuropathy, and idebenone, a CoQ10 analog, has been approved in the EU for therapy, and there is some benefit for the early cases, but there is really no benefit for prophylactic therapy in these patients. And there is a gene therapy that is in trials for these cases. And this is the condition. These are the ophthalmological features where basically with this bilateral painless vision loss, visual acuity is very bad. And this is a patient's perspective of a central scotoma. This is what he sees when he looks outside. And some patients may not show any fundal changes. And when you look at the retina, there is optic disc atrophy and optic nerve dysfunction on testing. And here are the extraocular manifestations. And this is what I want to stress to the trainees here. If you have a mitochondrial patient, you have the primary symptom, but make sure that you look at the other beds. And for Leber's, it's usually neurological abnormalities, non-specific myopathy, and importantly, cardiac arrhythmia. You may save a life if you implant a pacemaker or an ICD in a timely fashion. And fatigue is an overarching symptom in these patients. This is another one. This is a 35-year-old male, and I'm sure many of you have seen some of our patients come through the various ICUs. Here he is, 35 years old, presented with weakness for a week, and for the last few days before admission was more confused and less responsive, had visual difficulties, and he presented to the ED in status, focal seizures. And on labs, there was mild leukocytosis, which we think is an acute phase reactant from the stress, mild metabolic acidosis, but the lactate was the key, very high lactic acidosis. And he had some ketones, probably he was dehydrated and undernourished. And so when we looked at the mitochondrial DNA, he had a 43% heteroplasmy for a tRNA mutation for leucine, MTTL1, and this is the common 3243A to G is the common MELAS mutation associated with MELAS. And this is a characteristic MRI. You have the parieto-occipital region. It's a cortical stroke. it is non-vascular in distribution. And when you see this, many of us will react and say, could this be mitochondrial? Not just MELAS, but other mitochondrial diseases. So MELAS, the acronym stands for mitochondrial encephalomyopathy, lactic acidosis, and stroke-like. And it is stroke-like because the T2-weighted signals do not correspond to the classic vascular distribution in stroke. And it's a very canonical mitochondrial disorder, primarily caused by variants in the mitochondrial DNA. And there are certain diagnostic criteria. Category A lists the clinical symptoms, and Category B, the laboratory and the investigation criteria. And you need to have at least 2 in A and 2 in B to call it a classic MELAS. And even within families, the spectrum can be very variable depending on the degree of heteroplasmy and depending on which tissue has the most heteroplasmy in these patients. This is the commonest mutation, 3243A to G, but there are other points on the wheel, mitochondrial wheel, which can be mutant, and sometimes even some nucleogenes can be mutated to give you a MELAS phenotype. And as I mentioned, this is the top half is the classic MELAS MRI, where you have the large cortical lesions typically in the occipital, parietal, temporal lobes. Here they are. And you also see other patients with MELAS who have more scattered cortical lesions or more basal ganglia involvement, or even those with predominantly cerebellar involvement. So all of this, these are atypical cases, but this is the picture of MELAS. And the CNS manifestations, the stroke and MELAS, the belief is that the underlying etiology is primarily a seizure, probably due to some vascular event causing a seizure. So seizure control is extremely important in MELAS. And they can progress to develop dementia and executive function defects and even epilepsy in uncontrolled MELAS decompensation. Sometimes they may just have very severe headache and a very unusual headache. They can have hearing loss, neuropathy, psychiatric illnesses, and myopathy. And the cardiac manifestations, recently I had a MELAS patient admitted, and one of the cardiologists said, I've never seen such thick myocardium in these patients. Is that MELAS? Yes. So they do get this non-obstructive concentric cardiomyopathy in these patients, and conduction abnormalities are very common. GI manifestations are common, endocrine manifestations are also common. And so for you guys, this multi-system evaluation of a diagnosed patient and ongoing surveillance for these defects is really the key. And what we see is if you have optimized the management, the number of metabolic decompensations is low. You sort of, there's no real cure or treatment, but if you stabilize them enough, they kind of tend to sit on their perch and stay stable for a much longer period than if any of these go unaddressed. Anemia is also pretty common in these patients. So how do you treat? Primarily supportive, IV fluids, hydration, seizure control, etc. Avoid mitochondrial toxins. What are they? Valproic acid is one. Certain anesthetics are one. Prolonged use of propofol. A short burst of propofol is okay, but prolonged use of propofol causes the propofol infusion syndrome, affects complex 1. You don't want to use that. You may not want to use certain antibiotics like linezolide, which are toxic to mitochondria. You may not want to use drugs like metformin, which can worsen lactic acidosis. And for the acute stroke-like episodes, you control the seizures and you start arginine. We typically recommend a bolus. And for an adult, 10 grams per meter squared body surface area within 3 hours of stroke is supposed to rescue and limit the stroke. Arginine is a potent vasodilator, so be prepared for drops in blood pressure. And once you've given the bolus dose, you can maintain the arginine infusion for a few days. And now we are using citrulline, which is a precursor of arginine in the urea cycle, and it's in clinical trials, and overall hydration and nutrition support. And these patients usually do get out and stabilize. So that is MELAS. Moving along, these are mitochondrial DNA rearrangements. This is Cohen-Sayre syndrome, Pearson syndrome. They are usually sporadic. They are not inherited. But I did have a patient where my patient was a 2-year-old boy with Pearson syndrome, chronic diarrhea, pancreatic insufficiency, pancytopenia, etc. And while I was working him up, the mother walks in with fatigue, progressive external ophthalmoplegia, and myopathy, and she had had a muscle biopsy done and was waiting for the results. And the two of them had this large deletion, and the mother had Cohen-Sayre syndrome, and the child had Pearson syndrome. It's the phenotypic difference between the two. And they have a proximal myopathy in Cohen-Sayre, progressive external ophthalmoplegia, retinal degeneration that I'm showing, and conduction defects, cardiac conduction defects, and ataxia, and so on. And the brain MRI may show white matter hyperintensities and may have lesions in the basal ganglia. And if you do a muscle biopsy, you will find evidence of myopathy, particularly mitochondrial myopathy with ragged red fibers. So here is a case that I saw here. The patient was referred to me. I think she saw neurology here. She's 32 years old, diplopia since the age of 15. She had led surgery, and then she also had for surgery for CPEO. But really, fatigue was her primary symptom. And she wanted to have children, so she really wanted a genetic diagnosis. And no lactic acidosis, a brain MRI was normal, EMG showed mild myopathic changes, and the muscle biopsy was striking, ragged red fibers, deficient COX fibers, and abnormal mitochondria. So when they did the mitochondrial sequencing in the peripheral blood, it was completely normal. So she came to us as an unknown. And we retrieved the muscle and we sent the mitochondrial DNA studies on the muscle. And we picked up 40% heteroplasmy, 40% of the cells carried the single large deletion. It was not there in the peripheral blood, and this we commonly see in these single large deletions. So beware which tissue you are doing the study on. And so we made the diagnosis not of Cohen-Sayre, but just chronic progressive external ophthalmoplegia due to a single large deletion of mitochondria. And reproductive options for her are limited because we don't know what her ovarian heteroplasmy is, so she will have to take her chance or use a donor for reproduction. And this is another case that I followed as a fellow. She presented to me at 5 years of age with a Pearson syndrome, severe anemia, failure to thrive. And on the bone marrow, there were abnormal sideroblasts. So we sent the mitochondrial DNA, and she had the single large deletion. And I have been following her since she's 23 years of age. She developed type 1 diabetes at 9, easily controlled with a little bit of insulin. She developed a complete heart block, just fainted at a barbecue party on July 4th, and was picked up right away and had an ICD placement, very common in Cohen-Sayre syndrome, and then eventually progressive chronic renal failure, and developed congestive cardiac failure as a result of this, though the heart itself was functioning normally. So we said, okay, her real problem is the kidney. So let's replace the kidney. So she had a living-related donor transplant, did very well, came out of anesthesia within a few hours, extubated the same day, and she's now 3 years post-transplant. She has Cohen-Sayre syndrome, normal cardiac function, albeit has the pacemaker, some type 1 diabetes, some sensorineural hearing loss. But her biggest problem now is she's going blind because of the progressive vision loss. However, she's a college student and cognitively normal. And I keep put this out there because there is always a reluctance to do solid organ transplant for these patients. It works, and if it is timed well, it really improves the quality of life and the natural history of these diseases. And definitely, it's not something that is, always complication prone. Some of these children do well. I mean, they do develop complications, but not all the time. So those are the mitochondrial DNA. But what about the nuclear DNA, the respiratory complexes, the coenzyme Q metabolism, and all of that, and not to mention a whole bunch of mitochondrial DNA maintenance and repair machinery. So we have something like this. And all of these diseases now can be picked up on exome sequencing or next-gen sequencing. So when you suspect these disorders, please reach out for the genetic testing. Insurance companies are able to cover it, and if you have trouble, seek a geneticist. We will be able to get the prior authorization done for you. And the cost is about $2,500 now for the whole thing, and you get a result back in a week, 10 days if you ask for a rapid exome. And that is very, very impactful in terms of diagnosis. You don't have to continue this patient as a multiple sclerosis. You don't have to give steroids for a possible inflammatory myopathy when you'll actually be doing more harm. Inpatient exomes, etc., are difficult in the adult population, but on the outpatient side, we are able to manage quite well. And for the adult nuclear gene defects, this is a very important pathway. And as I said, our mitochondria are constantly dividing. And so there has to be a mechanism to replicate the mitochondria. And there has to be a mechanism to salvage and keep the nucleotide pool to make this mitochondrial DNA going. So defects in the mitochondrial replication machinery, the salvage of the nucleotide pools, and then the mitochondrial maintenance with fusion, fission, etc., are common nuclear defects in the adult population. And if these nuclear genes don't work, you get, if you do a blot, you get this is normal solid mitochondria, and you start getting multiple broken up pieces of fragmented mitochondria, multiple deletions, as opposed to the single large deletion that I showed you. This multiple deletions invariably represents a mitochondrial DNA maintenance defect. And if you look at the amount of mitochondrial DNA and the nuclear DNA, the normal is like this, nice amount of mitochondrial DNA, nuclear DNA, and here the amount of mitochondrial DNA will be less. So we call this mitochondrial DNA depletion and multiple deletions. Sorry for the terminology, but I hope this clarifies. So these are some of the disorders: polymerase gamma, twinkle, helicase, etc. TK2 myopathy, DGUAC, SUCLA2, or M2B. So if you read your mitochondrial textbooks, these, and the common are depletion, multiple deletions, depletion, multiple deletions. OPA1, which is the commonest cause of optic atrophy, about 60% of the patients, is a mitochondrial DNA maintenance defect. And then you have these tRNA synthetases. These are enzymes that help an amino acid latch on to its tRNA. And these tRNA synthetases are specific to each amino acid and specific to each mitochondria. So here are the aspartate tRNA synthase. Here is LARS, the leucine tRNA synthase. And look at the phenotypes: leukodystrophy, encephalopathy, Peral syndrome, the ovarian failure, sensory neural hearing loss. So a lot of these also have a representation in the adult mitochondrial clinic. Nuclear defects affecting mitochondrial function. So here is a female, 42 years old, sudden onset leg weakness, optic neuritis, was diagnosed as MS, but they were not sure, had some treatment, did worse with it. Brain MRI was negative, and the EMG showed sensory axonal neuropathy. And they did a shock neuropathies panel that was completely negative. So we picked her up and we did a whole exome sequencing, and we found polymerase gamma variants. And in retrospect, when we looked at the muscle biopsy, she had COX deficient fibers and she had multiple DNA deletions on the southern blot. And we continued her on propranolol because that helped her tremors, and we gave her some coenzyme Q, B complex. So these are some of the syndromes with pol gamma: progressive external ophthalmoplegia, ataxia neuropathy syndromes like MEMSA, SANDO, and then they can have a GI dysmotility disease, movement disorders, and less frequently myopathy, neuropsychiatric manifestations. In children, they have liver and brain and eye. So that is Alpers, Hutton-Locker syndrome, devastating. The thing with pol gamma is if you give a patient with pol gamma disease who has absolutely normal liver functions, you give them some valproate to control a seizure, they will go into fulminant liver failure. So you almost put it as an allergy. Do not use valproate in these patients. So that's something to remember in these patients. So this is a case that came to clinic yesterday. A 44-year-old with frequent rhabdomyolysis, and he had a statin myopathy, and exposure to statins is what started the rhabdo episode. And he was referred to genetics to rule out rhabdomyolysis, and we sent the next generation rhabdomyolysis panel, and he has a mutation in thymidine kinase. This is an important in the salvage of the nucleotides for mitochondrial replication. And the interesting thing with thymidine kinase is there is this deoxynucleosides, or in clinical trials, with very good benefit for these patients. And they look at the 6-minute walk test that is improving, the North Star ambulatory assessment scale, pre-therapy and post-therapy with significant improvement. Some of these patients are able to get off the ventilators. That's how significant the improvement is. And a biomarker, the GDF-15, is going down. It's very high in myopathy. With therapy, it goes down. So this patient is going to be referred for compassionate use therapy. Hopefully, this drug will get approved. And similarly, exome sequencing picks up guanylate kinase, another enzyme in the salvage. The phenotype is ptosis, neuropathy, hepatopathy, and an immune deficiency. And you treat them with deoxyguanosine and one of these purine metabolism drugs, and there is a significant mitochondrial recovery. And you'll never pick these up without doing exome sequencing. So I'm really making a case for early sequencing. And this is a last patient that I'll show you. This is a case that we saw here, 12-year-old, some developmental delay. He had a chromosomal microdeletion, so they attributed it to that. But at 10 years, he developed ataxia. And Dr. Susan Shin, she did the EMG studies and diagnosed a sensory motor neuropathy. And as that workup was going on, they found him to have complete heart block, and he had a pacemaker placed. And exome sequencing, because he had all of this, found variants in this topoisomerase. Topoisomerase helps the mitochondria as they are dividing to nicely separate out so that you're not clumped together. So if you don't separate out, you get clumping. And this is his cardiac biopsy, abnormal mitochondria with a lot of clumping of the mitochondrial DNA. We transplanted him. He did very well post-cardiac transplant, but at 10 days developed seizures and a subdural hemorrhage and infarcts. We are not sure if it is mitochondrial. We think it could just be the anticoagulation that he was on, but he's made a pretty full recovery and he's back to baseline. And there's been no overt cognitive decline. So we did this transplant 3 years ago here at Mount Sinai. So that's another organ transplant that we did. And in addition to these primary diseases, the mitochondrial machinery is very important for disorders like Charcot-Marie-Tooth, Parkinson's, Huntington's, Alzheimer's, etc. There are some very nice reviews on that. And so in terms of diagnosis, whenever you see these unexplained symptoms in more than 2 to 3 organ systems, think of mitochondrial diseases, particularly when they are involving the high energy beds and if it is progressive. And some of the biochemical markers like lactic acidosis and metabolic acidosis also help. And there is no single diagnostic investigation. We do a composite, including blood and urine studies, imaging, and molecular. And FGF21 and GDF15 are relatively newer biomarkers. And this is now our algorithm. As soon as you suspect, you go straight. If you think strongly mitochondrial DNA, you can sequence the mitochondrial DNA alone. Otherwise, sequence both the mitochondrial and the nuclear DNA. And then, depending on what you find, if you have a diagnosis, you're good. If you're still concerned, then proceed to functional studies like a muscle biopsy to make a further confirmation. And like I showed you in that case, you can also sequence the mitochondrial DNA in another tissue like the muscle in select patients. And these are some of the chemistries that we do. And this is MR spectroscopy showing you the lactate doublet that you see in affected areas. Here the voxel is placed on the cortical aspects, and this is the thing. We ask for this in our patients. And we can do scenario-specific panels, like we just did a rhabdomyolysis panel or a neuropathy panel, but more often we are doing whole exome or even whole genome sequencing. Gives you a lot of overload, data overload, but we still push through, and we've made some stunning discoveries of patients and genes with this approach. Here is some muscle biopsy showing ragged red fibers. This is COX-negative fibers with deep succinate staining. This is a normal muscle EM, and this is disordered muscle architecture on EM. Dr. Ron Gordon has helped us with some of our patients. And mitochondrial disease therapies, supportive, surveillance, and these are the toxins that I've been mentioning that you avoid in these patients. And here are some of the cocktails. We use nicotinamide, riboflavin, biotin, thiamine, folinic acid, and so on. And primarily, I use a multivitamin. I use B50, which is 50 milligrams of all the B complex vitamins, coenzyme Q, and maybe an antioxidant. And then I parse out the others. So some patients are on all of this, and all of this is not FDA approved. None of this is FDA approved, and all of this is a huge financial burden because they pay out of pocket, and many patients cannot afford. But select things like arginine, creatine for myopathy are helpful. And these are some of the doses. I'll give you a PDF of the slide so you can have it for reference. And then in clinical trials, I mentioned idebenone. Elamoprotide is a cardiolipin agonist. Exercise, resveratrol, and NAD precursors help in mitochondrial biogenesis. Rapamycin, arginine, gene therapy, some of these deoxynucleotides, and the transplantation. So these are the treatments that we do. A lot of them are on clinical trials. Many don't work, many fail. And then lastly, I'm going to leave you with this. This is now done in Europe, not yet approved in the US. What do you do with that woman who's got progressive external ophthalmoplegia who wants to have a baby? You can do this three-parent DNA approach. So what you basically do is you can take a woman who's got mutant mitochondria, and you can fertilize that oocyte, and you can remove the pronucleus and transplant it into a healthy donor. You fertilize that, you remove the donor pronucleus, but you put in the mother's pronucleus, and now you have the father, the mother, and the third mitochondrial donor. So this is a pronuclear transfer, or you can just remove the spindle and transfer. So these are approaches for mitochondrially inherited diseases where you cannot say autosomal dominant or recessive. So in Europe, there are children being. And these are some of the references. The Wellcome Center for Mitochondrial Diseases, they constantly update. So if you have a patient at 6 in the afternoon and anesthesia wants to know what precautions to take, you can type in Wellcome Center and you can type in MELAS or Concierge syndrome, and they'll give you recommendations as to what to do organ system wise. And you can show your anesthesiologist, do this, don't do that, and avoid this. So the clinicaltrials.gov is constantly updated with the trials. And thank you.
Thank you. I always knew the mitochondria was my favorite organelle. Has now been reconfirmed. Reconfirmed. So from a practical perspective, if you have a patient that you suspect, what is the pathway of referral here at Mount Sinai?
So that's a great question. So the mitochondrial center for us is housed in genetics. And so we have 3 attending physicians seeing. So it's me, Dr. Eva Morava, who's the metabolic chief, and Dr. Ibrahim El-Sharkawi. And we are all metabolic physicians as well. And we work with our dietitians. We have 4 of them who invested in these patients. And we have multidisciplinary collaborations with all of the pediatric specialties, GI, liver, heart, etc. And in the adult, we refer patients to Dr. Shin, Dr. Joanna Jan, that group, and Dr. Shiano, and depending. So that's how you refer. So you can just put in an EPIC referral, and we have a genetic counselor who works with our patients and a couple of nurse practitioners who also see mito. So if you have any, you see, and many of us are consulted when we are on inpatients. There's a metabolic service that's 24/7, and one of us is on call all the time. So if you have an inpatient, you can call. And I've actually got approvals for this molecular testing if I've made a case to send it out even as inpatient. I mean, these are patients who've been here for 2 months, who've had brain biopsies, and it's a question, what do you do prognostically, and and so I've had approvals even on the inpatient, though that's very rare. But on the outpatient setting, we are pretty lucky, and we get by because by the time the patient comes to us, they've seen 7 doctors, and have a burden of disease that justifies the cost. Yeah.
I don't know if there's a lot of data about but there's a lot of in the long COVID world about like mitochondrial dysregulation on a lot of these patients. All these specialists and are on a lot of these treatments like for enhancing mitochondrial have these like acquired mutations? Like, should we be
Plenty of research in that realm. So the purpose of this talk is what we say primary mitochondrial diseases where they are inherited, etc. But that type of secondary mitochondrial dysfunction, with COVID, which causes some of these genetic perturbations, and also other secondary mitochondrial dysfunction, like even hypoxia or a cardiac failure, etc. If you look at the mitochondria, they are not working properly, and that is why when you have a crush injury or you have a patient who's got multi-organ arrest, why does your lactate go up? Secondary mitochondrial dysfunction. So that is a huge area in itself. So this is more like primary defects, so genetically inherited. But there is a lot of research. It's a very good question.
Any other questions? If not, we have a lot to think about our mighty mitochondria. Thank you very much.
Thank you.